and the T20 finals are not far away. Why must you keep your ace of spades for the end? So if you use the published conceptual approach, an earlier and more aggressive intervention approach, it provides a rapid glycemic control and therefore improves the patient's glycemic profile, gives him a good metabolic memory, and thus it reduces the incidence of complications. So this yo-yo up and down then becomes a smooth pattern. So the longer the patient lives with better euglycemic environment, the later his internal media develops complications. The B-SMART, which is basal early strategies to maximize A1C reduction with oral therapy. The basal-only regime is the most convenient initial insulin regimen, beginning at either 10 units a day or 1 to 0.2 kilogram per body weight units, 0.1 to 0.2, depending on the degree of hyperglycemia. Timely insulin initiation leads to long-term reduction in complications and with better outcomes. This should be injected at an appropriate time, usually evening or bedtime, in line with the prescribing information. The analogs of basal insulin provide the advantage of flexibility of timing, making it simple and less intrusive, and glargine 300 second generation offers definitely more flexibility in the timing of injection, and it can be given at any time of the day. So this insulin goes for the gaps, and you could be sitting over all the holes of golf and winning. What do you do with the other rarities after initiating basal insulin? Now this is a question that is not addressed often. People only say write basal and forget about it. Metformin could be and should be continued if there are no contraindications. Incretin-based therapy, SGLT2 inhibitors, could probably be continued. SGLT2, yes, certainly, because of the cardioprotective effect. Thiazolidinediones should be reduced or probably even discontinued. Sulfonylureas should be continued, albeit at a lower dose, because sugar control will be better and you don't want hypoglycemia till the patient realizes he is not missing his sulfonylureas. Then you gradually phase it out, because you don't want to squeeze the beta cells all the time. What are the benefits of early basal supported oral therapy? Early basal supported oral therapy. So it's a mix of everything. The basal insulin is capable of restoring the residual beta cell function in short term, providing the basis for a better response to different maintenance therapies. Again, this insulin attenuates the risk of microvascular complications in all patients. And early basal insulin adds on and lowers the risk of hypoglycemia and weight gain, which is considered safe. Thus, even CV patients, if you mix and match. You have to tailor it to the requirement. You have trousers. Some people need back pockets, some people side pockets, some people no pockets at all. You have to fit your pocket into his pocket so that everybody pockets the HbA1c price. So what is the benefit of second generation basal insulin? Why has basal insulin evolved from Gen 1 to Gen 2? Remember, glargine 100 and detinib were developed to overcome the limitations of the earlier NPH, etc. Now the new longer acting basal insulin, glargine 300 and degludec, have since been developed with less variability and more prolonged durations of action. And you can see in the graph down at the bottom to the right how glargine 300 lasts longer and delivers better results. You'd ask me, what is the difference between glargine 300 and 100? A smaller volume of injection of glargine 300 versus glargine 100, smaller subcute depot of the same, different absorption kinetics, the gradual release allows different and slow homogeneous absorption. Distinct glargine 300 PKPD profile compared to glargine 100. So glargine 300 has the same molecular structure, the same mode of protraction and metabolism as glargine 100, but the absorption, the amount of vehicle and the depot is much better and facile. One other thing is better with glargine 300, and I'll come to that. Besides the more stable and prolonged PKPD profiles, it also offers relief from the timing of injection. Because of its long duration of action, more than 32 hours, the flexibility of plus or minus 3 hours, whether you finish the clinic in the evening or in the late night, or whether you have a party or you have an early meal, you can play around with glargine 300. Better efficacy with lower hypoglycemia and lesser weight gain with glargine 300 compared to glargine 100 at 1 year. And if you see, all factors, nocturnal as well as anytime hypoglycemia, is better because of a flatter, not undulating, smooth profile with glargine 300 as compared to glargine 100. The weight factor is extremely important because you feel 1 to 2 kilos is not much. Ask the insulin user and the poor diabetic who's walking on the treadmill or going for a walk and feeling his waist all the time. How do you switch from first generation basal insulin to second generation? You switch because there is significant improvement in the pain score. There is ease of use, where you see that switching from first generation to second generation, better quality of life with patients who need these glargine injections. The force to inject with the pen gives you clearly the switching preference. Less pain, ease of use, and less force to inject. So what are the advantages? Longer duration of action, greater flexibility and administration timing, flat profile so reduced glycemic variability, can be easily titrated, lesser anytime and nocturnal hypoglycemia, which leads to better blossoming patient satisfaction, definitely lesser weight gain, and the most important for both you and the patient, better efficacy. So it definitely provides the winning edge. Not that the patient is losing out with glargine 100. I'm not here to bury one and resurrect another. I'm here to tell you why one is better than the other. And if you have a better product, and if your patient wants the ultimate, you have to give him the winning edge. Quick practical considerations. What is the initiation dose? 0.2 units per kilo. You can inject any time of the day. Stick to the same time as far as possible. Can OADs be continued with glargine 300? Yes, but you have to decide which ones you want to keep and which ones you want to discard. Titration regimen. You can titrate daily or once in 3 days or even weekly, depending on your confidence, the confidence of the patient, and you can even titrate up to 0.5 units per kilogram per day. What is the unique advantage? We have gone through long duration, less variability, flexibility of timing, low weight gain, and easy titration. One last thing about this pen. It's excellent, it's accurate, it's convenient. It's easy to use. 95% of first-time users of any insulin rated glargine 300 pens to be the best. The volume is very little, only 1/3 of the volume as compared to glargine 100. And the lowest injection force, older the patient gets, the worse is his coordination, more difficult for him to push and pull. So if you have 450 units, very little problems as far as titration, because you turn the pen and there is a lock. You don't lose and you don't waste. And you have these beautiful disposable must-fit cartridges where you have to see that the two work together. So with this reusable pen and a dedicated cartridge, I know a lot of inhalers. You use trans caps and rescue caps with transhalers and everything is interchanged. You don't interchange this. It's not hit or miss, it's only fit the best. So you have a reusable pen with a dedicated cartridge and insulin delivery is simplified. There's a penalty-free dose correction. It allows you to correct or over-diluted dose with a needle fitted without wasting. Mechanical last drop stop. Previously dialed dose exceeding the remaining content. Nothing goes wrong. And the pen dimensions are easy. I'm sure you walk around into the exhibition and some of you would have this pen for demonstration. So in summary, early initiation is a must. That responsibility is that of the physician. You cannot shuffle your feet, but at the same time, you can give him OADs. Glargine 300 is the best in the game. If you're initiating, you can even initiate with the best so that the convenience of the patient and the physician is met with. It has an array of advantages for better efficacy and safety. And if you delay this intensification, you are the guilty one because you will give him micro and macrovascular complications. So don't get locked in. Let your footfalls and footprints be in the right direction towards the latest, translating the science of basal insulin into Gen Next. Thank you.
Thank you so much, Hemant, for a wonderful presentation. I love the last slide.
Yeah. So with this we move to for a second take. Can I have an introductory slide of Dr. Jyotidev Keshner? Okay, yeah. So I think so in this afterwards, after we finish all three sessions, we will have a question and answer session. So we all know Dr. Jyotidev Keshner. Yeah, sir, please. He is chairman at the Diabetes Research Center, managing trustee, P.K. Shudder Trust, editor-in-chief, International Journal of Diabetes and Technology. He is well known by conducting monthly diabetes education via YouTube channels. Many of you have gone through. Publishes a monthly internet-based free diabetes newsletter for past 13 years. First author for Indian guidelines on vaccination insulin pumps. He is a pump man in India. Across the India, people know him as a pump man. So whatever the new discovery in the pumps and technology, you can ask Dr. Jyotidev Keshner, sir. And pioneering in the field by conducting many trials. He's going to explain to 2 days on leveraging timing voice to improve the patient outcomes. So over to you, sir.
Thank you, Patient Goswami, and very honored to be along with Dr. Shashank, Dr. Hemant, and Dr. Sanjay. So thank you very much, Sanofi, for giving me an opportunity to be part of this landmark clinical trial. And I was so fortunate to listen to the original presentation at AGTD 2 weeks ago. And the presentation was from Richard Beckstein and the team. So from this is a continuation of the previous lecture by Hemant sir. And this is leveraging time and range to improve the patient outcomes. And how we can leverage from the existing basal insulin. So of course we are shifting our focus from the conventional hemoglobin A1C, from the conventional glucose meters to the new gen metrics and for the new gen technologies, and that is the beauty of modern medicine. So modern medicine, I believe, is totally different from the indigenous medicines. We keep on innovating and we keep on changing, we keep on advancing, And with every advancement, there is an improvement in the lifespan. There is an improvement, definite improvement in the quality of life. And that has happened with the advancement with the insulins, especially the second gen basal insulin such as the U300 larger. So look at this innovation. Some of you could have already seen this in one of my presentations recently. And this is the new non-invasive glucose meter. I think this is disturbed over there. I'm sorry about it. Let me see whether I can show it once again. So this is how it looks like. And on the left you can see this is the 135 is the value in the glucose meter. And I can simultaneously try to measure in the non-invasive meter. In the non-invasive meter, there are two sensors at the front and two sensors at the back. And there is no pricks, there is no bread, so there is no strip involved. And you need to press on the sensors with your thumb and with your index fingers. And within 15 to 20 seconds, you will get to know your glucose value. Of course, there are a lot of limitations to this new technology of a non-invasive glucose meter, and this is a prototype. It is commercially available, but it is very high. It is very expensive, almost 30,000 Indian rupees. However, this is going to be a reality in another maybe 3 to 4 months' time. And that is how technologies and treatments are advancing. So definitely we are, as a community of clinicians and practicing diabetologists, we have adopted glycemic variability and percentage time range in our practice. And this has become a necessity because this is now a recommendation from the scientific organizations, and this has become a necessity because glycemic variability is a challenge in those getting treated for diabetes and those who are diagnosed with diabetes or even pre-diabetes. And excessive glycemic variability and suboptimal control of diabetes or suboptimal percentage time range remains still as a limitation of challenge in our routine practice. And if my patient with diabetes or my colleague, and he can be from the department of nephrology or from neurology or cardiology department, because these are the usual doctors or specialists whom we are referring our patients to, if they are asking me, why Dr. Zudadev now we are recommending percentage time range as a routine evaluation, and why you are recommending newer treatments such as the U300 large to be adopted for your patients with type 2 diabetes. What is the reason? Why there is a significance for percentage time? And these are my answers. If the percentage time range is reduced from 70 to 60 or from 60 to 50 or from 50 to 40, 10% reduction can result in 65% increase in retinopathy, 40% increase in microalbuminuria, 25% increase in neuropathy. And our colleagues as doctors and our patients are very much concerned about death. And this is the statistics on death. The TIR, when it is reduced by 10%, just 10%, it increases the cardiovascular mortality risk by 5%. And it increases the all-cause mortality by 8%. So that is the evidence that is currently available on leveraging percentage time and range in our routine practice. And again, if there is a question on who is recommending, it is recommended by the ADPD, it is recommended by the international consensus, it is recommended by the American Diabetes Association, it is endorsed. ADA in the clinical practice guidelines have even published a prototype, AGP report, and the American Diabetes Association for the last 3 years they have endorsed that percentage time range need to be used and it is associated with the risk of development of microvascular complications and need to be used for the assessment of diabetes control. So if you are a doctor who is practicing based on the new recommendations, every year, maybe every 6 months, there is a change which is happening with the clinical guidelines based on the evidence from the clinical trials. And here is evidence to use the therapies and the technologies which are aligned with these recommendations to reduce the time and range in our patients. And The data used to be a big data, because remember the days when they started using the continuous glucose monitoring. It was in 2004 we started using CGM. So every 5 minutes you will get a report. Every 15 minutes from Libra or Librepro you will get a interstitial glucose value. So what are you going to do with this big data? Big data analysis is a big, huge challenge. And again, the measurement of glycemic variability, GV target need to be less than or equal to 26%. And these are all numbers which need to be resolved. Because an ordinary physician like you and me, I cannot sit and analyze all this data. I cannot go through 10 or 20 pages of a CGM download, and that is why, and that is how this has become simplified with the international consensus. So the report which need to be handed over as per the American Diabetes Association AGP report will consist of 3 components, and the middle component is the ambulatory glucose profile, which represents the 14 days of recording. And this is just a recap for all, because you know very well, but this is just a recap. The timing range should be between 70 and 180 milligrams per deciliter. So this is the percentage timing range. And in general, for those without any complications in type 1 and type 2 diabetes, getting treated for type 1 or type 2 diabetes in your clinic with probably no extra risk involved, then the percentage timing range need to be above 70%, and this corresponds to approximately 17 hours in 24 hours. And for time below range, and that is a time below, which is spent below 70 milligrams per deciliter, should be less than 4%, and this corresponds to 1 hour and 24 hours. And the time below level 2 hypoglycemia, that is 54 milligrams per deciliter, need to be less than 1%, which corresponds to 15 minutes in 24 hours. And the time above 180, which is level 1 hypoglycemia, should be less than 25% of the time in 24 hours. So that's very simple. So this has been made very simple. It has been simplified in the new recommendations. And for a person who has the risk or propensity to develop complications due to hypoglycemia, already an elderly with multiple comorbidities, the timing range between 70 and 180 need not be above 70. We need to keep it only above 50%. That means you can even go up to 70, but initially it should be only above 50%. Considering the fact, considering that significance of avoidance of time below range. Here, there is only one level below 70, and that is less than 1%, which corresponds to 15 minutes. So you need to prevent, the ulterior objective is to prevent the consequences of hypoglycemia. And the time above range less than 50%, and above 10% of the time above 250 milligrams per deciliter. So that is the current recommendation. So the question on, we have the second generation basal insulins. So what is the evidence level? So we have close to a dozen studies comparing the 2 second gen basal insulins, Glargine U300 against degludec. So now we are here as a team, and this symposium we are discussing the in-range study. And I am so glad that this is the first face-to-face presentation of in-range study in India. Am I right? So the first face-to-face presentation. And this is now considered as a landmark clinical trial comparing the 2 basal insulins, U300 Glargine against U100 degludec in type 1 diabetes, and those are the other patients with type 1 diabetes. So please remember, this is the world's first study, and this is presented for the first time in India. And this is a study using time range comparing the 2 second generation basal insulins in a head-to-head clinical trial in adults with type 1 diabetes. And this is a broad view of the study design. You can see the study design over there. So I will make it very simple. So it is a multi-centric randomized clinical trial. So randomized means it is a very, very well conducted clinical trial. A total of 343 patients, adults aged between 80 and 70 years with type 1 diabetes, hemoglobin A1C between and inclusive of 7 and 10%, and the subjects were earlier on a basal insulin, and that basal insulin was a first-gen basal insulin. So to enter into this study, to fulfill the inclusion criteria, they should never be on a Degludec or U300 glargine. And this is how the screening was. And the target was to keep it between 70 and 100 milligrams per deciliter. And how do you titrate the bolus insulin? This is a basal bolus regimen in type 1 diabetes. The bolus insulin is titrated based on the postprandial glucose levels to be kept between 130 and 180 milligrams per deciliter, avoiding hypoglycemia. And of course, the CGM was again repeated, and this is a CGM which will be considered for analysis. And this is again a blinded CGM at the end of the study. And that was after 8 weeks of titration of both these insulins. What were the endpoints? The primary endpoint, of course, is the percentage time in range comparing the two insulins. And the secondary endpoint is calculation, the mathematical calculation of glycemic variability. So we were having the efficacy endpoints, the secondary efficacy endpoints. Any diabetes related clinical trial, you should be performing a hemoglobin A1C estimation baseline as well as at the end of 12 weeks. And then the study again looked into the time above range and time below range. What about the safety endpoints? Other safety endpoints. So here we have the data on hypoglycemia, the overall, the nocturnal, below 70, between 70 and 54, below 54, that is the level 2 ADA hypoglycemia, and then also looked into other adverse events of interest. And these were the baseline characteristics between the study groups. They were matched for the age, an average age of around 42 years, and the body weight, and this is the body mass index, 20 years from diagnosis of type 1 diabetes, and an average age of around 42 years, and age of diagnosis 22 years. And they were started on a basal bolus regimen, on an analog basal bolus regimen, approximately 8 to 9 years ago. So all these groups, or either groups were matched for all these characteristics. And what about the existence of complications? And this is the baseline characteristics pertinent to the underlying complications during the entry into the clinical trial. And these are any complications, retinopathy, neuropathy, nephropathy, all were again matched. So the baseline characteristics were absolutely comparable between the two groups, randomized to either glargine 300 or Degludec 100. So let me now move on to the study results. So these are the primary endpoints. So the study met the primary endpoint. In range study met the primary endpoint of non-inferiority of U300 glargine against Degludec 100, and this was demonstrated for the percentage time in range. So it is comparable. It was statistically not significantly different between the two insulins, 52.74 and 55. And with respect to the secondary endpoint, again, in range study met the secondary endpoint of non-inferiority of glargine 300 versus IDEC 100. And that is with respect to glycemic variability, 39.9 versus 41.22. So in every diabetes related clinical trial, especially when we are discussing insulin, for the doctor, for the common man, it is again back to the same question, what are the hemoglobin A1C reduction? These subjects were earlier on a first-gen basal insulin, and they were switched over to a second-gen basal insulin. So both the insulins resulted in a significant reduction in the hemoglobin A1C from 8.34 down to 7.38, and from a baseline of 8.29 to 7.51 at the end of 12 weeks. So this is 0.75 versus 0.92 for these two insulins. So moving on to the data on hyperglycemia. So this is the topic of interest to everyone. What about the prevalence of hyperglycemia between the two insulins? So this is on any time, that is the overall hyperglycemia. On the left I have the incidence and on the right the number of events. So you have the data on severe hypo, documented hypo. Remember, this is SMPG documented hyperglycemia. And you have the data on less than 70, between 70 and 54, and less than 54, that is level 2 hyperglycemia. So if you look at these numbers and the documentation, incidences and rates, there is a number of events of hyperglycemia. And this is pertaining to all those hypos which are listed here. Various categories, all of them are similar between the two treatment groups. So they are exactly similar between the treatment groups. And moving on to nocturnal hypoglycemia. Nocturnal hypoglycemia can be defined as hypo is documented between 12 a.m. and 6 a.m. early in the morning. And here again, for all the categories of hypoglycemia, they were exactly similar between the two treatment groups. So moving on to the safety concerns, and this is treatment emergent adverse events. Patients with any treatment emergent adverse events, again similar between the two groups. What about the death? This is again an area of interest. Have anybody died due to this insulin? Because anyway, we know the real world data, we have been using both these insulins for quite some time. So absolutely no deaths in any of these groups. And those patients will have stopped this insulin. Permanent treatment discontinuations, again 0 in both the groups. So the safety profiles which are documented, they are exactly similar to the real world experience with these two insulins, and they are absolutely safe. So the safety concerns are none for these two insulins. So these are the take-home messages. So the important concluding messages from the in-range study. So this is the only one, the world's first study comparing the two second-gen basal insulins with continuous glucose monitoring, which the primary endpoint was met for non-inferiority. The secondary endpoint was met for non-inferiority for glycemic variability. So we have non-inferiority for percentage time range, non-inferiority for glycemic variability, and there were no safety concerns. And there were no unexpected safety findings in this study. So now the strengths and limitations of this study. Strength, I will say, we have the top researchers who have conducted this study. So these were the top researchers who have conducted and presented this study at the ATPD meeting in Barcelona 2 weeks ago. So truly a randomized and a multi-center study. The CGM was blinded. The CGM was not open. So the subjects were not given the privilege of adjusting the dosages based on the interstitial glucose values. So it is unbiased. So the CGM actually, since it is blinded, the data can be compared between the two insulins. And the CGM data is collected for the recommended period of time. So when you are conducting a continuous glucose monitoring as per the international recommendations, you need 14 days of CGM, of which 70% of the data should be viable for measuring a meaningful percentage time range, and that corresponds to minimum 10 days of available data, and that is also available for the subjects. Of course, there are limitations for the study. It was an open label design, and we could have probably gone for a continuous glucose monitoring for more number of weeks or more number of months to make more statistically significant comparisons. So remember, though we have these recommendations from the international consensus, this is a non-reimbursable market in India, in South Asia. So we have this recommendation for our South Asia. Dr. Sanjay Agrawal is part of this team and he is the next speaker. Dr. Menchi Sabu. So we have made this recommendation where we have made subtle changes in the upper and lower limits. But more importantly, we have made for this non-reimbursable market the frequency of repeating the AGP and continuous glucose monitoring. And that is based on the current report on time in range and the time below range, whether it is less than or more than especially if it is more than 4 or 5%, then you should be repeating more frequently. Otherwise, probably, if it is a stable percentage TIR, you need to repeat it only once in 6 months. Ideally, in all patients with type 2 diabetes. In all patients with type 2 diabetes. But in a scenario where the patients are not willing for a CGM, or in a scenario where the patients are unaffordable for a continuous glucose monitoring, then I will say that we should be recommending those therapies such as the U300 Target, which is already proven in evidence-based studies, in evidence-based recommendations. Percentage TIR, improvement when compared to the first-gen basal insulin, and a significant improvement in the glycemic variability. So in conclusion, IMBRACE study has met both the primary and secondary endpoints with respect to percentage time in range and improvement in glycemic variability. So in modern medicine, and this is where I started reading, technologies and treatments, they keep on changing and they keep on advancing, and this is only to improve the quality of life and to prolong our lifespan. So I will recommend all of you to adopt on those newer treatments, such as the new second-gen basal insulin, without any delay, because if you are delaying the therapy, you are actually denying that privilege from your patients. Thank you very much for your patient hearing and for your
Excellent talk, sir.
You have safely moved all of us in the time range. We will take question and answer session after the third session.
So we now move to the next talk. And the next talk is by Dr. Sanjay Agarwal. All of us know him as the erstwhile Secretary of Diabetes, Research Society for Study of Diabetes in India, RSIDI. And he's really going to talk on basal insulin optimization, a patient-centric approach. Sanjay basically is the director of the Agile Clinic Diabetes Care and head of Department of Diabetes and Medicine at the Ruby Hall Clinic, and also a senior diabetologist at the Jahangir Hospital. He's a fellow for American College of Physicians and Endocrinology. He's been very active in the writing groups of RSHJ guidelines, and he's the current face of RSHJ. He's author of Clinical Atlas in Diabetes. Edited a very beautiful monograph on insulin, and he's a faculty, teacher, clinician, and a good friend of ours. And he's really going to talk about patient at the center of the universe when it comes to optimization of basal insulin. Sanjay.
Thank you very much, Shaukat, for this kind of introduction, and thank you very much, Sanofi, for giving me this opportunity to present this lecture. I think every day we keep discovering more and more aspects about basal insulin. Okay, thank you very much. So we keep discovering more and more aspects about basal insulin. We just had 2 excellent lectures by Hemant and Jyoti on how the evolution of basal insulin have occurred in a clinical practice. And not only that, are we sort of looking at just fixing the fasting and seeing how we can reduce glycemic variability. The greatest challenge is how we combine it with oral agents. And of course, once we move from basal oral therapies to basal boluses or basal plus therapies, how well we can adopt this from the patient's perspective as well as from the doctor's perspective. And this is where I'm really going to talk today about that. Can we retain our patients more and more on insulin therapy? Because that's where the greatest challenge lies when we introduce insulin therapy to our patients. So introducing it is good, but how many of them can we sustain it in the long term and keep them to the goals that we prescribe is the biggest challenge that we face in clinical practice. So this is going to be the overview of my talk. We're going to discuss about the how of basal insulin initiation in diabetes management, the why and how basal insulin titration in diabetes management, And titration inertia, is it a reality? Addressing the unmet need of hypoglycemia risk with basal insulins. Addressing the unmet need of titration algorithm complexities with basal insulin. Insulin intensification strategy, a stepwise progression towards glycemic control, and basal plus concepts and practical aspects. So let me address each one of these briefly and put an overview about the suggestions about how can we handle these problems when we see patients in practice. So let's look at the first one, is let us understand the how of basal insulin initiation in diabetes management. Now, we all know that every individual is different, their requirements are different, and we can't sort of put them in silos to think that everybody should have the same insulin titration process or the initiation process, and how much of insulin do we need to give. There are many calculated formulas to derive how we sort of start the insulin dosing of a patient who's insulin naive. But here's one of them, that we can either do it from a body weight perspective or from looking at from the glycemic perspective. And here you've got from the body weight perspective. So you have three individuals, one with weighing 60 kilograms, 80 kilograms, 100 kilograms. And here looking at the A1C value. So anybody with an A1C of less than 8%, the same patient, if you multiply that by body weight into 0.2 units per kilogram, your requirement of insulin changes as a starting point. Similarly, if you have somebody who is more hypoglycemic and the baseline A1C is more than or equal to 8%, then you add a little extra insulin to the patient and you give a 0.3 units per kilogram. And similarly, the entire titration process of starting the baseline insulin changes, and you can see from weight basis how much you can calculate the baseline insulin requirement of an individual patient. Now, we have seen some expert opinions as to how the titration process should happen. And there are two expert opinions that I would like to really talk about. One is the B-Smart expert opinion. And in this, what they really did was, they looked at the basal only, and they made it very simplified. So you begin with 10 minutes per day, or you titrate at 0.1 to 0.2 units per kilogram per day, depending on the degree of hypoglycemia. So the higher the baseline A1C that you've got, obviously you need a little more insulin for the patient. And if you have a lower A1C cutoff, then you probably require less amounts. So you titrate according to what the baseline A1C the patient comes to you. Or you start at flat 10 minutes per day, monitor the patient's fasting sugars, and then you go up with the basal insulin requirement depending on how much of a drop that you get. So if you get more than 30% drop of the fasting blood sugars, then you don't change the titration. You just allow the same dose to work. And if you find that there is a plateauing of the fasting value, then you probably go up on the dose. So you may require to titrate the patient's dose weekly or twice a week, depending on, of course, how your blood sugars are really doing. The other one is, of course, the Delphi expert opinion. And in the Delphi expert opinion, you start with 8 to 12 minutes of basal insulin as an initial point. And then you give 4 to 6 units, or you can give a lower dose with hypoglycemia is concerned. So, patients who are sort of challenged in terms of their body weight or comorbidities or risk for hypoglycemia, you always underdose a patient at the starting point, because at the initiation point, if somebody experiences a hypoglycemia, it becomes a big deterrent for that person to continue insulin therapy. So it's more practical that you start with a lower dose of initiation, and then you build up on that dose, once you see the glycemic response. And some of them, we all know that they have a very, even with smaller doses of insulin, have a faster glycemic response. And these sort of patients, they suddenly go into a hypoglycemia. Again, if you have got somebody who, let's say, are renal compromised patients, they require lesser amount of insulin because the degradation is slow and there's a stacking of insulin that tends to happen. So in these patients, you probably will start with a lower amount of insulin for the patient. And then, of course, you sort of follow on a weekly basis the patient and titrate depending on the glycemic responses once a week or twice a week. The next step is, of course, let us understand the why and how of basal insulin titration. And here I want to talk about that why our patients sort of stop optimally controlled. And this was one study which looked at, and they said that almost 86% of our patients with insulins and oral agents, and approximately 80% of the patients who use insulins only are not at goals. But that's a tall mark to really make. And what is the reason why patients are not at goals? There could be a progression of the diabetes and there is a slow response from the clinician to react to that. So although you're getting a sort of a failure of the beta cells happening, more insulin requirements, but your insulin dosing is not keeping pace to how much the patient requirement is, and you're underdosing the patient. The other thing will be that there is an increase in associated comorbidities, or there could be insulin therapy which is required by the therapy, but you're not giving it enough, or you're not initiating in a timely manner. Or despite insulin therapy, the glycemic goals may not be routinely achieved, and that's one of the reasons that you may be sort of getting a suboptimal control. So you have to be proactive, you have to take steps early, and you have to constantly monitor the patients who are on insulin therapy for their glycemias to see how much of dosing an individual patient requires. Now here's a good graph which sort of correlates between the A1C responses, the fasting plasma glucose response test, and how much of insulin requirement the patient will tend to have. And you can see here that if you sort of look at patients who are doing an optimal response or optimal titration process stepwise, and you see this sort of, you go from left to right, you see over here that A1C dropped from 9.3% all the way up to 6.6%. And if fasting plasma glucose dropped from 211 all the way up to around 130, you can see that this has been achieved by a stepwise up titration of the basal insulin that the patient tends to get. So you can achieve targets provided you proactively up titrating the dose requirement of an individual patient. So you can see here that the starting point of basal insulin is almost about 8.6 units per day. But to get effective titration goals, you have ended up giving almost about 30 to 40 units per day. And this has been a gradual up titration process that we do and see that the patient can get their response. We have different algorithms. So one of the algorithms you can go 2 units per 2 days or 3 units per 3 days or 1 unit per day, and you can keep titrating the fasting plasma glucose till you get fasting blood sugar close to about 120, and then you can stop there. But that's a little sort of, if you're going too fast, there's always a risk of hypoglycemia that the patient can experience. So you need to sort of optimize how much titration you want to do given an individual patient profile. Now, this is basically a survey that was done with healthcare professionals and patients and their attitudes to basal insulin therapy. The key information was regarding the basal insulin titration, which how many patients were getting reacting to the information that was being given to them. So when they interviewed healthcare professionals, they said that almost 75% of the healthcare professionals discussed the titration process at the initial visit of the patient. And then the patients who were interviewed, they said that only about 16 to 28% of patients remember such discussions. Many of them, 32 to 42%, were unaware of the need to titrate basal insulins. And only about 28 to 39 recalled the mention of time needed to reach glycemic goals. So you can clearly see the gap where the healthcare professionals are saying that we discuss it more than 75%, and the recall by the individual patient is less than about 25%. So obviously there is a communication gap that's happening between the healthcare professional and an individual patient. And we probably, the message out here is that we need to have a proactive approach. We need to have a team-based approach by which our patients are counseled more often. They're being sort of decked with the clinic, with your team, who can keep talking to them about titration process of basal insulin and how they need to sort of document their blood sugar profiles and take necessary action of going up or down in terms of the dose requirements. Now, this was by the enhanced study, and you can see here that there is an achievement of goals of A1C of less than 7% was achieved of less than 50% of the patient population study. And I'm sure that if we look at the Indian population, this is going to be no different at all. So why is it that despite all the tools that we've got, we're still not achieving adequate amounts of goals of treatment? So we need to sort of look at this more aggressively and see that how can we counsel our patients more effectively to see that more and more patients sustain the goals with effective amount of studies, effective amount of dose that we give to patient. This was another study, the IDNTS Wave 7 India subgroup analysis, and they looked at why was somebody sort of suboptimally controlled. And one of the reasons was the fear of hypoglycemia, which was considered as a key barrier. And if you look at the bar diagram on the right, two important reasons that stand out was lack of insulin up titration, and the second was lack of experience in self-management of insulin dosing. And these are the two key points to prevent somebody from getting to optimal goals. So obviously, we need to teach our patients there's enough there to show that patient-driven versus doctor-driven, what is the best titration. And we know that patient-driven titration is good and it's probably sometimes better than doctor-driven titration. And you have to empower the patients to learn the titration process and see how they can get their fasting goals much effectively. Because if you get your fasting goals achieved, it's going to translate into post-meal goals also getting achieved, and the overall A1C coming down, into prescribed limits. Now, this is another study which was basically an interview of top 5 physician perceived patient barriers to initiation and titration of basal insulin therapy. And they looked at what were the barriers from the physician's perspective. So patients' reluctance, unwillingness to consider basal insulin treatment was seen about 35%. Patients' non-adherence to existing medication regimes, or patients' inability to self-monitor the blood glucose in sufficient frequency. Patient concerns about out-of-pocket costs and patients' lifestyle include diet and exercise. Well, some of the major barriers that the physician survey reported were patients' inability to self-titrate and a barrier to insulin titration process. Now, we'll come to the next part, that do we really have something called the titration inertia? And let's look at what could be the 3 barriers that we talk about for titration inertia. We know that there is a progressive decline in glycemic controls because of the disease progression and the increased comorbidity that the patient may eventually land up with. And despite use of adequate insulin therapy in large prospective studies, the desired glycemic control is not achieved. So very often what happens when you have comorbidities, you tend to have a little step back approach that should I do adequate titration, should I suboptimally titrate, or should I go to the goals, and what are the risks that the patient is going to carry in terms of hypoglycemia, which may probably increase the chances of morbidity or mortality. So you tend to go a little slow in terms of titration, and in the end result in suboptimal control, which may be one of the reasons for the progression of the comorbidity itself. So you've got to be very judicious as to, it's a kind of a tightrope walking that you're doing as to what should be your optimal control that you need to give a patient. So do not underdose the patient, don't overdose the patient, and go slow in terms of titration would probably be the message that would be there from this kind of a situation. So I just want to sum up to say that what could be the factors contributing to titration inertia? It could be from the healthcare professional perspective, a reluctance, or because of the problem of weight gain, or the fear of hypoglycemia, or the effects of insulin therapy on quality of life, lack of education, lack of constant self-glucose monitoring, complex regimes, and this is one of the most important barriers that, when we give all kinds of complex titration regime to the individual patient who's not equipped to handle this sort of a regime, it's probably a situation where the patient says, I don't want to do it. And he just says, let me just go to more simpler forms of therapy. Or then, of course, if you're too tight in terms of the regime that you're giving, and lack of flexibility in terms of dosing, then these would all be some of the reasons why somebody would not titrate their doses, and this could be termed as a titration inertia. Now, hypoglycemia always remains a problem and a deterrent for us to go in terms of intensification of therapies. And this is basically seen in one of the studies, where they said 2 out of 5 patients with diabetes reduce insulin dose after mild hypoglycemic episode. We know that hypoglycemia begins hypoglycemia, and one attack of hypoglycemia sort of predicts hypoglycemia. Because the patient underdoses, becomes hypoglycemic, he does defensive eating, gets weight gain, and all this ultimately results in hyperglycemia of the patient. And this was sort of, if they looked at it from the physician's perspective, And they found that this aggressive control is probably more out of caution with the gynecologist than with the primary care physicians. So the consequences of the fear of hypoglycemia can result in decrease in tight glycemic control, poor adherence to therapy, reduced willingness to intensify therapy, and compromised compliance for taking therapy. And we've seen that this has been studied in different insulin regimes. So here's one where they looked at basal insulin versus premix. So they had very similar glycemic controls, but the risk of hypoglycemia was much higher with premix insulins. And if you look at the number of confirmed hypoglycemic events per patient years, whether it's overall hypoglycemia, symptomatic hypoglycemia, nocturnal hypoglycemia, all this was at a higher rate with the premix insulins. And if you compare ida-gas versus insulin glargine U100, there is almost about 86% higher overall confirmed hypoglycemia with ida-gas. This probably is because it's been driven more from the aspart from point of view rather than from basal to basal. So I think the increased risk of hypoglycemia comes from the aspart part of the co-formulations. But if you look at the percentage of patients who achieve an A1C of less than 7% without confirmed hypoglycemia, the U100 glargine stand out much better in terms of comparison with ida-gas. Now, we need to sort of address the unmet need of titration algorithm with basal insulins. And here's one couple of studies that how fast are you going to titrate the patient. So this study, inside landmark treat to target, they looked at glargine U100, and when they were sort of the patients were very strictly and stringently controlled with tight algorithms involving stringent fasting plasma glucose or SMBG values. They showed that the attainment of glycemic goals was at the cost of hypoglycemia that was seen very frequently. But the same thing in the Atlantis and Gold A1C, where they looked at optimal glycemic control and they titrated slowly without pushing the patient to cause hypoglycemia, had better responses in terms of sustaining the patients on basal insulins. And here are some of the ways that you can titrate. So you could do a fixed dose titration process, or you can do based on fasting plasma glucose titration that you can see what you want to do. I just want to summarize to say that towards the end of that talk, some of the barriers to patient-centric approach is low level of awareness among both patients and physicians, constraints on patient time and resources, low rates of adherence to therapy, insufficient glucose monitoring using SMBG devices, undue medical and financial burden. So, you give too many SMBGs to be done to an individual patient. Remember, it costs, and each strip costs. And if the cost of monitoring is much more than the cost of treatment, then the patient may not really do it. So you've got to be very judicious in asking how much of SMBG profile that you need to give an individual patient and how frequently, and if the patient is well controlled versus uncontrolled, how often are you going to ask the patient to do the point of care testing. Some of the solutions that we can have is we need to, as I just said, that we need to optimize our SMBG monitoring. We need to have more patient support programs to educate and handhold the patient when the patient is being initiated and intensified on insulin therapy. We need to have a motivation and encouragement for the patient to see that somebody is talking to them all the time. And they're shown, of course, that, as I just mentioned it well back, that empower the patient to self-titrate because he knows best what he needs to do. And these, through various efforts of the patient-driven titrations, are much better than doctor-driven titrations. Okay. So when you really stop titrating basal and add primary insulin, when the requirement for basal insulin goes up beyond 0.5 units per kilogram per day, or you are not achieving your A1C goals despite having at target the fasting plasma glucose, or you find that you've achieved the fasting plasma glucose but your post-prandial values are still on the higher side, that's when you need to introduce a primary insulin for the patient. And when you decide that, you probably start with a basal class. You look at the mean that gives the highest glycemic excursion and we give a branded insulin with that meal and titrate it so that you can fix that meal, post-meal glycemic values, and that may sort of, iron out the rest of the post-meal glucose values that you can do with this basal insulin with a branded insulin. But if you find that the other glycemic values are still not at goal, other post-meal glycemic values are not at goal, then you can do it the second meal or third, and eventually the patient may require a full basal bolus therapy to be given to the patient. Typical study which you looked at, of course, the glargine versus glargine plus glulisine, so it was basal versus basal plus, and given basal plus, are you getting a better control for the patient? And this was the answer that they wanted to see. And here you can see in the point of care study that adding glulisine to glargine further improved the glycemic control. You can see the control group and the intervention group, and you can see the end point. Despite that the A1C control is much better, and the percentage of people achieving a goal of less than 7% is far higher in the basal plus than in the basal alone therapies. So, you titrate the branded insulin very similarly to how you do the basal insulin titration, and you need to go slow. Of course, there could be a meal-to-meal variation that the individual patient can have because there is standardization of what we eat, and there could be a meal-to-meal variation. So you may need to teach your patient, depending on, of course, what kind of food the patient eats, that you need to go up or down in terms of how much of what you're going to eat. And this is where probably a branded analogs come very much of handy, because if the patient is unsure what he's going to eat, then you can ask him to eat and then inject himself. So I want to talk with some key messages that titration inertia due to fear of hypoglycemic weight gain leads to inadequate insulin up-titration and poor glycemic control. Systematic yet patient-friendly dose up-titration strategies with basal insulin helps achieve glycemic control. Simplicity and convenience of one's daily regime with basal allows the patient empowerment for effective insulin dose management in Indian settings. Progressive nature of diabetes may result in subsequent intensification of insulin treatment to achieve glycemic control. Rapid-acting and long-acting insulin analogs may link endogenous cranial and basal insulin secretion. A stepwise intensification of basal insulin glargine with single injection of insulin glulisine can be considered in clinical practice. I think that's the end. Thank you very much for your patience.
I request all the speakers to come on the dais. So we will have one question for each speaker, as we are running short of time. So I invite all audience participants to ask the question.
Any questions for Dr. Hemant, Dr. Jyoti Kesavdev, Dr. Sanjay Kumar? Yeah, doctor had a question. Can anybody give the mic please from the team? 1 minute, please.
Sir?
My little practice in diabetes, I would like to know certain doubts and clarifications. One thing is, there has been a diet pattern which is different from the Western diet. Our people eat more during lunchtime and less in the evening time. Now in the morning, we heard hyperglycemic events are more common during night time. Now if we are going to start GLA 100 in the night time, it's going to create a lot of hyperglycemic episodes. So would you like to stick on to bits or would you like to change the pattern of injection time?
We didn't get the question clearly.
So you're saying instead of giving it at night, give it in the daytime?
Because already our lunch is refrigerated quantity also we take.
By your point of dietary habits is accepted. Second generation or even first generation looks for a continuous action, especially the second generation, which has a flat profile. You can give it at any time of the day, but to this patient of yours who loves his lunch, I would take a leaf out of Dr. Agarwal's lecture and add glulicine at lunchtime. So that will look after that peak.
Thank you. So, Doctor, one clarification. Normally, the BIDS therapy was postulated because they wanted to control the fasting blood glucose, which was switching off the hepatic glucose output. And that was the basis of the basal bedtime insulin and daytime sulfonylurea. So, that was the primary basis. And then Hemant has alluded to it. Any other quick questions? Or yeah, go ahead.
Sir,
Identify yourself.
I am Dr. Vinod sir from Andhra Pradesh.
Great.
Sir, Glargine 300 versus Zydex 100, the cost and which will you prefer in your private practice?
Dr. Jyotidev, he is the best person to answer that because he has the CGM on everybody. So he will tell you whether he is friends with some of you who is sponsored or not, or he is friends with me. It's a tight question you ask him. Okay, he has to be diplomatic, I am certain he will be.
My dear Shashank, the question was actually to you.
So the evidence-based answer has to be answered by a randomized control trial. And the RCT done head-to-head of Deglutec versus Glargine has been very clear-cut that efficacy and safety parameters are almost the same, except that during the titration phase, hypoglycemia in the Deglutec arm is a little more. So that data is clear-cut on the RCT standpoint. Novo could never replicate that study. They had a lot of problems in their replication study of a similar nature. So on evidence-based, probably if I give 16 out of 20 to Sanofi, I would give 14 out of 20 to Novo. I'm being straight and direct on evidence-based. If I'm a teacher in a school and I have to give marks, that's what I would give.
The cost,
I would definitely ask
the cost, which is more costly.
So 1 minute, I'm not going to ask each one of them because each one of them use a lot of basal insulin in their practice. So 1 minute, I'm coming to that. So I'm asking that in just clarity. Cost is in the mind of the physician. Cost to cost, I don't think is a major challenge because second generation basal insulins will always be a little more expensive than the first generation, and the first generation insulins are already generic. So with the genericization of basal insulin, that really doesn't matter. But from a health economic standpoint, two other advantages of the U300 Glargine are in the renal world and the elderly world. Again, the BRIGHT sub-study has some data to show some directionality. But I'm going to ask each one of our panelists, who are experts in their own right, the glycemic variability bit to Jyotidev, the practitioner's bit to Hemant, and the final word will be with Sanjay because he is the custodian of our city.
So, as a continuation to what Dr. Shashank has said, I discussed about the in-range study. And in-range study is the only study currently available with the CGM. And the continuous glucose monitoring data has not been actually completely used for the presentation of the AGD. So they are still working on the CGM data, and the CGM data will let us know the exact differences between the two insulins, because this is done in a type 1 diabetes population which can be extrapolated, because these are subjects where there is an absolute insulin deficiency. So these are the patients where the study need to be conducted. And the CGM data will let you know whether there is a reduction in nocturnal hypo, whether there is a reduction in the overall hypo, because the data that I have presented today is based on the SMPG data. And with respect to cost effectiveness, I think Dr. Shashank has already given you the valid points. We need to be using our clinical judgment, because these two insulins appears to be almost the same from all the currently available data. So now you have to decide which insulin need to be used, because these appear to be interchangeable in clinical practice. That is what we have learned from the available data. And the Glargine 300 appears to be cheaper when compared to Deglutec. Thank you.
Dr. Hemant.
See, let me take you back 5 or 7 years. You have been prescribing Tetini or Glargine. So you are familiar with Glargine. So you'd rather eat your sister-in-law's food when your wife is not there, rather than go and eat your neighbor's food. So I am more comfortable writing you 300 Glargine than it's come from that.
So last word, Sanjay. Dr. Parikshit has a question for you. Yeah.
This is the management of diabetes by insulin disorder. Plus minus.
No, this is a second generation basal insulin symposium.
That's for the type 2 diabetes?
No. Are we talking only about type 1 diabetes here?
No, we are talking on all basal insulin.
Okay, so
all diabetes.
And I am getting an impression that the entirely type 2 diabetes is just managed only by insulin titration. No, that's the impression that I got after listening to it. So the whole idea is that insulin is one of the important agents required by type 2 diabetes in many situations. I agree with you. But many times it's due to the failure of the lifestyle modification, whatever word one wants to use. In recent times we are seeing obese people continue to be overweight and they are on the drugs and you are increasing the insulin and you are so happy that the SMPG is remaining wonderful, HbA1c is good, patients are not really doing so well. So while you are over-focusing on the titration of insulin, there are also other factors like what kind of a diet are they taking, are you trying to look into it? You are not doing an intensive management. Most of the patients don't in fact require intensive management as is being done many times. It's just my comment, Shashank.
So I think I just want to end up giving the last, as Shashank said. I don't want to really make it sound a very bad sort of a judgment, but remember that we have got a number of basal insulin, but they starting right from NPH onwards. So you've got NPH still that is available in the market, you've got 800, you've got Glycine 200, 300, Regular, all the basal insulin. Remember one thing in all the trials, irrespective of whichever basal insulin you use, the glycemic response is more or less similar. What is the difference is the rate of hypoglycemia that makes them different. So one factor is of course the rates of hypoglycemia. So obviously the newer insulin, so if you look at compare U100 versus U300 or Regular for that matter, you have a more flatter action profile with the newer basal insulin as compared to U100. So if you sort of put titration upward beyond 0.5 units per kilogram, all basal insulins tend to peak. So although they have a flat action profile below 0.5 units per kilogram, at higher values they do tend to peak and give hypoglycemia. Now that is sort of circumvented with the U300 as well as with the Regular. The other thing is there is a tailing effect that we tend to get with U100. So towards the end of the effect, you find that there is a slow hyperglycemia that tends to happen, which is probably taken care of with the U300, because of the longer action profile they tend to have. Alright? Also the flexibility of patients, to, as somebody just asked them, should you take it in the morning or evening? That flexibility quotient that comes in with the U300 or Decodat. So each of these basal insulins have individual characteristics. If you look at only the glycemic response, they're all the same. They're really no different in any way. But if you're looking at an individual patient which is giving you a problem and you want to see how can you overcome that problem, then these characteristics are the ones that help you to decide which one should you choose from. If you look at Decodat, it has probably less weight gain as compared to the other basal. So in obese patients, what would you tend to use? So it's very different. But this is a way that we can approach the patient when it comes to basal.
Thanks, Sanjay. So 2-3 other points which come in. So you asked the question head to head. Day-to-day versus what is the cost difference? If you take 20 units, which is a standard dose for basal insulin, 2,600 is the cost of Decodat, 1,600 is the cost per month for Peugeot. So obviously it's cheaper, 1,000 rupees cheaper. Clear cut. See, because economics matters. Second thing is that what Dr. Basal Kumar is saying is that we need to initiate and intensify appropriately and correctly, and insulin is just not an arbitrary prescription, it needs to be titrated appropriately. That's the second point. The third thing is what Parikshit was talking to me as all these three stalwarts were speaking, that in general, insulinization has gone down. People who don't need it are on tons of insulin, people who actually deserve it are not on insulin. At the same time, with the advent of second drug, third drug, fourth drug, fifth drug, sixth drug, insulin use has come down. So I'm asking again, in a reverse order, starting from Jyoti Dev, then to Sanjay, last word will be with Hemant because he comes out with some testers. Okay, that's going to be the final comment. I know this, the organizer will throw us out, but they have given us 15 minutes for discussion and only 6 minutes are done. The question is very straightforward. Okay, that when you are using insulin, has the use of insulin come down? The use of Parikshit's question, I'm translating it for him. Has the use of insulin come down with the advent of multi-therapies in diabetes? 2 drugs, 3 drugs, 4 drugs, 5 drugs or GLP-1 analogs? starting from Jyotidev, then Sanjay, and last word Hemant. I'm already Parikshit is going to simplify it.
Yeah, and you highlight the importance of using continuous glucose monitoring in technology. And Dr. Basal has highlighted the importance of lifestyle modification. So, with the added technology, and how many percentage of insulinization has gone down in your practice?
In my practice, the answer is no. Because we are aggressive users of insulin. But in general, I would say, because as Dr. Shashank said, because of the multiple newer oral therapies, in general, insulin use has probably gone down and it is very dangerous. And if you look at the average A1C level, it either is remaining the same or it has also gone up. So we need to use insulin judiciously. And with respect to continuous glucose monitoring, it is not just to change the therapies, it is meant for changing the lifestyles primarily. Because we do CGM, and when you assess the CGM data, in more than 99.99% of the CGM, the dietitian and the exercise therapies, both of them have actually intervened. And the therapy changes are usually executed only in 30%. So that is in general what we are doing in our practice. Thank you.
So it's a difficult question to answer really, and the answer will be yes and no. We've seen that obesity is a major driving epidemic, which is driving the epidemic of diabetes also. And with all the newer agents that we've got now, with GLP-1 analogs and SGLT2 inhibitors, which are driving, along with, of course, a lot of technology-driven lifestyle management programs that is available today, I think all of these are really sort of, hitting hard on the obesity epidemic. Plus the advent of, healthy eating habits that is being promoted aggressively. And good agents for control. There is a certain element that more patients are probably getting controlled with OHAs, with the newer therapies that are there. What it also means is the time taken to insulinization is getting more prolonged. So it's not just how many patients are getting on insulin therapy, but the time to insulin therapy is getting prolonged. But we all know that progression of disease happens and everybody is going to end up with insulin therapy at some point of time. So it's not that you can do it with insulin therapy, it's just a question of timing of when to initiate. That's probably getting more prolonged rather than anything else.
Thanks, Sanjay. Last word from Hemant Thakkar.
I think too much of science. I'm going to liken this to a buffet. The buffet, the last thing you have in the buffet is the dessert, which is insulin. Finally, everyone gravitates to it. You can enlarge the buffet table. We used to have only Chinese and Indian food, now they put Spanish and French food. But that doesn't take away from the dessert. In fact, people want to eat dessert before even anything else. So I think insulin has its own place. I agree with my fellow panelists and chairman that it is getting postponed, and what doctor said, that we are trying to tailor OHAs to the lifestyle. But if you want results, there is no two things that insulin is the best nuclear weapon to break open Ukraine if you want to be.
Thank you so much. So with 100 years of insulin coming up, we are going to wind up. I can see Dr. Makkar will otherwise throw us and evict us out. We are definitely, before time for the schedule at the time which we got it. We are still 7 minutes before time. Okay, but still we are finishing with it. There are two speakers there are two people who want to ask questions. The panel is very much available for a dialogue, and we hand it over back to everybody. Hemant, I'd like to comment, we are celebrating 100 years of insulin, which is the theme of this meeting. And it is the oldest drug on planet Earth. Still people have reluctance and hesitancy, like we had COVID vaccine hesitancy, but still we are unmasked here. Similarly, we should be on insulin, because that's what our portal vein has. Thank you.
Thank you for the delicious lectures we had here.